Education Foundation, India. And today we have once again Professor A.K. Pal from Kolkata, who really does not need any introduction. And to tell us what he's going to speak about today, uh, I would request Dr. Janki Sharan Bhadani to let us know what he's going to, the crux of his talk today.
Thank you very much, sir. Dr. Pal sir is teaching us about what are the do and don'ts in DNB practical in last minute, what you can revise, you should know, and so the crucial things. So I think without much delay, I'll over it to Pal sir.
Okay. Good evening, Dr. John and Dr. Janki. So I think it will be going to be a very, very important class, sharing of knowledge. That is a crucial last-minute tips for success in orthopedic postgraduate practical examination. So, so now how to prepare for practical? Now this is a 7 days only the left for the final examination. Now every students, my beloved students, is now very very anxious about what will be going on, how will you prepare the last minute preparation. So my this is the by just suggestion is these are the program should be done at least 3 to 6 months before the final date of examination. There is a listing of these different topics which will be discussed in the practical examination, like the listing the long and short cases, implants, equipments, medicines, list of the operations, approach and the surgical anatomy, list of flying oral questions, emergency situations, and list of the practical orthosis and prosthesis to be discussed. Now, clinical presentation is a crux of the examination. And for DNB, the most important is the OSCE. We previous classes we discussed about the OSCE, how to crack the OSCE. Different types of OSCE is now going on, like clinical types, knowledge type, affect like the practical type. Now the OSCE system is also coming in a very big way. We will concentrate for this evening. We'll dedicate about the clinical examination. Clinical, apart from the OSCE, the rest part of the examination, that is a long case, short case, or all the clinical cases, as also the table viva. Now, for the longest short case, these are the common cases we can make a list. For the hip, we have to concentrate on the ununited neck femoral fracture, malunited trochanter, TB, tubercular arthritis, avascular necrosis of the femoral head. And for the spine, the most important is the KD spine, as also the prolapsed intervertebral disc, which is commonly in the cervical, that is the lumbosacral spine. And for the short cases, there is a elbow, knee, and shoulder, ankle. Most important, there are the infection like the chronic osteomyelitis and the tuberculosis, the deformities, neoplastic, neurologic, and the congenital idiopathic. Now, these are the broad categories. Now, how to crack in the day of final, actually the finale, the grand finale, there is examination. That is see, first of all, how to give in the approach. So this is the broad category of the disease, orthopedic diseases, like traumatic disease, infective disease, inflammatory. So once you have completed the history and the examination, now the first question will be what is your diagnosis. Now, so always think of what is the broad category. Now, suppose it is a traumatic disease, so we have to tell the dysfunction starts from the moment of there is a trauma may be a significant trauma, it may be minor trauma, trivial trauma, it may be repetitive trauma. Now, how to know it is an infective disease? Now, what is in favor of infective disease? So, it is suppose it is a tubercular disease, or it is a chronic pyogenic disease. So, chronic pyogenic disease, there will be a chronic discharge. So, this is a chronic discharge that is more than 3 months, or at least more than 6 weeks. So, there is a discharge of pus. So, that from the history we can tell it may be an infective disease. So, in this way, we have to categorize the disease. Suppose that is inflammatory. How to know it is an inflammatory disease? disease like the rheumatoid arthritis or the ankylosing spondylitis. So basically, the inflammatory arthritis basically it may be polyarthritis disease. So it may be polyarthritis that is there, or maybe polyarticular or the monoarticular disease. But there is a pain which is it is different from other diseases. The pain at the wrist relieved by the activity. There is a morning stiffness, and most of the course of the disease it is a waxing and waning of symptoms. So in this way, you have to know so we have to start, sir. That is why I'm telling it is a inflammatory disease. What are the implement? How do we implement this sort of a category? So there are 7 S questions. That is, what is the sex? Some diseases predisposed to some sexes, like the ankylosing spondylitis. Most commonly, it is a male. Rheumatoid arthritis. Most commonly, it is a female. Like this. Age, yes, definitely. The ankylosing spondylitis. It is a young active. That is a 50. That is 25 to 35 is the commonest age of presentation. Now, starting, it may be whether it is acute starting or it is a gradual, is acute onset or the gradual onset. So that is why it is 7S symptoms. S is a site, it is a single site or the multiple site. Site, maybe it is a unilateral or bilateral. And symptoms, it may be local and systemic. Span, that is duration maybe it may be prolonged duration, that may be chronic or acute. How do you know it is a chronic disease? Chronic osteomyelitis, that means that is the if the symptoms persist more than 3 months. 3 is the category, so it crosses the 3 months, definitely you can tell it is a chronic disease. Now the spread, how it progress. So if some diseases are progressive. So among this is the category. Some diseases are progressive, some diseases are non-progressive. Suppose it's a traumatic disease. Suppose it is a road traffic accident, it cannot be progressive. So, but it is a tubercular arthritis. It is a progressive disease. So, in this way, how do you know that it is a progression? What are the from the history? What are the particular history to be taken to know whether it is a progressive disease? I will discuss later on. And lastly, the severity. Severity means if there is a systemic and cardinal symptoms, systemic features like the history of fever, there is loss of appetite. Cardinal symptoms, there are 5 cardinal symptoms which should include in the history of present illness. That is a bladder involvement, bowel involvement, there is a loss of appetite, sleep, and there is significant loss of body weight. So if these 5 cardinal features are there, disease is severe enough. That means it may be a malignant disease or it may be a chronic infection which is spreading all over the body. Now, the etiopathology. Etiopathologically, all the categorical disease may be divided into most of the which common that is the mechanical disease, inflammatory disease, or infective neoplastic. Now, what are the salient features I've already told? Basically, mechanical disease. How to differentiate this mechanical, infective, and inflammatory? That is a category of the common symptoms. There is a pain. So, how the pain differs in different category of the disease, I'll just discuss in the next slide. Now, the symptoms of progression. Now, there are 3 features. If there is a deterioration of symptoms, if there is a gradual restriction of the activity of the daily living, or there's a gradual reduction of the walking distance, definitely the disease is a progressive disease. Example, it is a tubercular arthritis or it is a metastasis. That means it's malignant disease. So, these are the disease of symptoms of progression. Now, this is a very, very important category of the pain. What is the difference between rest pain and the night cry? So this may be asked in the examination. The rest pain is the pain experienced after taking some rest, even in the supine position in any part of the time, any part of the day. It may be in the morning, it may be the middle of the day, in the night, everywhere. But for the night cry, that is a pain causes awakening from the sleep that requires sound sleep. But the sleep is disturbed. That sound sleep is required for muscle spasm should be completely ameliorated for the rubbing of the eroded articular surface. So that is why the patient becomes asleep. But if the sleep is disturbed, sleep is broken in the middle or the late part of the night. So that is the night cry. So it requires a deep sleep. But the rest pain, whenever the patient takes rest, that causes the rest pain. So that is a different. Now, this is the very, very important slide. How to differentiate between the mechanical category of the disease, inflammatory, and the infective neoplastic. Mechanical means a structural defect that leads to symptoms like the pain. Whereas the inflammatory, it is an inflammatory disease. It is autoimmune disorder. They may be where this is cell may be considered as a foreign, and that leads to antigen antibody complex. Now, infective neoplastic is specific etiological factor. Now, even in a very, very busy OPD, or even in any examination, a single question, what is your aggravating factor and what is your relieving factor, that can categorize the disease. Now if the aggravating factor is the activity and the relieving factor is the rest, that means it's a mechanical problem, that is a structural defect. Just opposite, that means the rest is the aggravating factor and the activity is the relieving factor, that is the inflammatory one, as I already told. So in the rest, there is antigen antibody complex is deposited, and there is a reduced venous return and the lymphatics, and that causes the inflammation. Once the activity starts, venous return increases, lymphatic return increases, and that washed away, and the pain reduces. That is why the activity relieves the pain in case of inflammatory. Whereas infective and neoplastic, as the cause is constantly present, so there is activity is the aggravating factor, where there is no relieving factor. So in this way, you can easily categorize the disease. Now, the distribution of pain is also very, very important. So to understand that what is the disease process. Now, if it is a non-geographic, that you cannot make it out, so patient cannot localize that this is the actual area of the pain. There is a very sinister significance. There is a diffuse or funicular pain that can happen from the inside of the body, maybe from the spinal cord. There is a diffuse or funicular pain. Whereas if it is a geographic on, that is anatomical in, that means patient is complaining of pain around the knee. So that means it is a localized, that may be due to some trauma, or that means a degenerative disease leads to inflammatory one. And again, if it is a wide distribution, suppose pain is complaining of the whole lower limb. So that may be radiation pain or maybe referred pain. So we have to clarify. Now, if it is a mechanical pain, if it is produced by the activity and relieved by the rest, that is a mechanical pain. Now, the claudication pain is a special type of pain. Now, claudication may be vascular claudication, it may be neurogenic claudication. Again, very simple questions. If the patient has to come out from a long distance from the railway, so is the patient, you can ask the patient whether you are getting pain during the getting up during this aero bridge, during getting up or getting down. If there is a patient is complaining of going uphill, that means there is a going against gravity, that means the vascular problem. So pain is this aggravating factor is the going uphill. Whereas if the patient is complaining of going down from the aerobridge to the platform, then the patient is complaining of pain, that means that means it's a neurogenic claudication. Why? Because during the coming down, there is a patient, the spine is extended. So that is the extension of the spine that reduces the canal and the canal diameter, as also the neuroforaminal diameter, that leads to neurogenic claudication. Whereas going uphill, everybody tries to flex the spine. That is that the flexion increases the diameter of the canal diameter and the foraminal diameter, and that reduces the pain. So they are going uphill, it is a vascular claudication. Going downhill, there is a neurogenic claudication. There are several other factors by which you can easily differentiate the vascular and neurogenic claudication. Now, examination protocol of the orthopedic cases is a very, very simple. There is a 7 broad heading, and every broad heading has a 3 subheading. I'm not going into detail. I think everybody knows. Now, this position. Now, what is the correct position? Now, see, there are 2 positions seen. Now, what is the correct position? Basically, so you have to follow the steps. We should not jump. So for the inspection, there are some prerequisites. What are the prerequisites? Prerequisites should, that is, patient should lie on a hard couch. There is a hard bed, as you can see here. Hard bed is well illuminated, so that if we want to see the lumbar lordosis, so in the hard bed, we can see the light from the opposite direction. That is one. Next prerequisite should be the spine should be straight and the limb should be as parallel as possible. Limb should be as so in this case, see on the left side, so the limbs are not parallel. Actually, this is internally rotated, so this is not the ideal situation. But whereas these are the limbs are as parallel as possible, and in that case we can find it out, the patella is going far away from the roof, so there is a the external rotation at the femur, but where it is compensated by the distal part of the tibia. but there is a wide gap. So this is a genuine deformity. So always, so in that case, we have to check this sort of finding that has to be confirmed in palpation. So always we have to choose the exact verb. What should be the exact verb to be uttered during the inspection? So inspection, that means my lower limb appears to be, looks like that. In that case, my lower limb appears to be externally rotated at the thigh, whereas it is neutral or internally rotated in the lower part of the leg. So and that appears to be that is knees appears to be far away from the midline. So it maybe there's a genuine deformity. We can tell like that. So appears to be, looks like, this is the actual verb to be taken. So even this sort of picture can be given in your OSCE, and you have to ask whether this which one is the exact proper position for inspection. What are the inspectory finding like this? Now, how to prepare for the any case. Once you complete your case examination, these are the 5 standard questions it is asked in the examination. What is your provisional diagnosis? What is your differential diagnosis? What are the points in favor of your diagnosis? How to rule out the others? And lastly, the management. Now, if you ask the how to manage the case, in this question, there are 3 questions are hidden inside. So, what are these 3 questions in the management? Management means there's confirmation of the diagnosis by investigation. That there are 3 types. Investigation means it is a non-invasive investigation, like the radiograph; semi-invasive, like the aspiration, like that diagnostic aspiration; and third, it is a invasive investigation, like the incision biopsy. Now, planning of the treatment. Next course of the management is the planning of the treatment. Again, there are 3 types of planning. That means it may be conservative treatment, it may be semi-conservative treatment, like the traction, like this, or it may be it is a operative treatment. So once you confirm your diagnosis by the investigation, then we have planned for the treatment. And next is the counseling. It is coming in a very big way. And now the most of the examiners, they like to know how will you counsel the patients. So if you go step by step without jumping, it would make a very important step, very important impression for the examination. Now, what are the points to be counseled? Now, the any patient's relatives, they are very much eager to know what happened. That means what is the diagnosis. Next point is what to be done. That means what is your planning, how to plan for your treatment. And lastly, the third question is very important. So doctor, will it be cured or not? That means we have to know, we have to tell all the pros and cons of the treatment, as also prognostication. So you have to tell, you have to disclose all the bad prognostic indicator, if any, and also the complications. Now, components of the diagnosis. This is a very important. Now, any disease, any orthopedic disease should contain this sort of components. First is the anatomical component. That means whether it is a bone is affected or the joint is affected. I will discuss how the joint is affected, how to know that. Next is the etiological diagnosis. This is the category I've already discussed. It may be traumatic, infective, inflammatory, like this. Next is the duration. It is very important. Duration is so that it is a few days duration or few months duration, because that depending on that we can plan. Next is the complication, whether it's the joint complications, joint is stiff or unstable, or it is a normal, it is a neurovascular deficit is there or not, and especially for the lower limb, whether there is a limb length discrepancy, limb is shortened or lengthened, like that we have to mention. Next, lastly, we have to identify the subject. That means that this sort of problem is present in a pediatric or the mature age group, in a female, in which occupation. Suppose we are dealing with the hip cases, hip arthritis. We have to know whether the occupation is a labor, or it is a high tech that is a counselor or high tech worker who works in sitting. So depending on that, we can plan for the treatment. And lastly, the dominance of the side. If it is affecting the upper limb, we must tell whether it is a dominant or not. Because if it is a non-dominant side, we can opt for the options which may not be the operative. So in that case, some suboptimal result can be supported. So dominance is very important. Now, etiological, I already told, these are the mechanical, like the congenital defect, trauma, tumor, infection, post-op, even the inflammatory, infective, it may be natural infection, it may be following open injury or iatrogenic, neoplastic, metabolic, degenerative, it may be primary, secondary. Most of the cases, all there is now secondary, no primary or degenerative diseases. And if there is no cause is found, it is idiopathic. Now, the bones and joints, how to know whether the bone is affected or joint is affected? Now, what is the common diseases? Bone is usually present with a deformity, fracture, or healing complications. Joint is a mechanical stiffness, or it may be due to deformity, synovitis, arthritis. So these are the enumeration. We have to find it out which one it is. So just I have for the students' help. Just I have made it easier. Now, how to find out the anatomical abnormality? How to know that this bone is affected? Now, bone is affected. Bone say that leaves some footprints of the bone affection. So, what is these footprints? Like the shape of the bone should be deformed in different planes. So, you have to palpate it carefully. It may be thickened. It may be broadened. Its surface may be irregular. You have to compare on the other normal side. And most important, it should be tender. So how the bony tenderness should be taken out, rule out the soft tissue tenderness. This is the clear clinical expertise. Now for the joint, joint may be deformed in different planes, and movements may be normal or reduced with or without pain. Movement may be increased, abnormally increased movement with or without pain. So if suppose it is a chronic osteomyelitis or tubercular spondylitis, that must be presented with bony tenderness. Suppose it's a tubercular osteomyelitis following the carry spine. So there must be tenderness. It is common in the D12L1. So must be tenderness of the spine D12L1. So how do you know it is a chronic osteomyelitis of the tibia? So there must be tenderness at the bony irregular or thickened area, and also there is some deformity like and the kyphosis, scoliosis like that. Now, how to know the joint is affected? Now, how do know it is a tubercular arthritis or any type of arthritis? So that is the answer is pain is coming out from the joint motions only. That means if the patient is at rest, there is no pain. Once it starts movement, there is a pain. But once movement is ceased, pain is also ceased. So pain is coming out of the movements that indicates is arthritis. Now this is a very important slide for the hip diseases. So see, there are several. All the hip diseases can be diagnosed. So just after finishing, the students will be asked what are the points in favor of your diagnosis. Now suppose it is a stiff hip, it may be painful or painless, and depending on the range of motion may be absolutely nil, painful but absolutely nil, painful, terminal restriction, painful, it's a global restriction. So if it is absolutely nil, so basically if the pain is present, that means it is inflammation. If it is a terminal restriction, it is a synovitis. If it is a global restriction, arthritis. Whereas painful range of motion on attempt of doing movement, pain is the range of motion is not there, but on attempt of doing movement, patient is painful. That means maybe a fibrous ankylosis. Whereas there is a range of motion, some restriction. Some restriction means if the other movements are normal, suppose it is a coxa vera, so it is only, see, this is a mechanical problem. So some restriction is a mechanical, some other movements may be normal, maybe excessive. So this is a mechanical problem. So if it is a coxa vera, the abduction and the internal rotation is only restricted, whereas the flexion may be absolutely full. Whereas if it is a slipped capital femoral epiphysis, so the other movements may be absolutely normal, whereas the external rotation may be excessive. So this is a case of slipped capital epiphysis. Now, if it is a painless, absolutely no range of motion, that may be a bony ankylosis. So this is in this way you can differentiate. Now, the low back pain, again, if it is an intermittent pain, diurnal variation, so it may be in the daytime, that is a activity increases, rest relieves, that is a mechanical pain. So that may be spondylitis, spondylodisthesis. So any disease can lead to mechanical pain. But in the middle of the sleep, the rest I already discussed, the rest increases, pain, the activity relieves. That means the inflammatory pain. That is why the inflammatory pain is it is commonly complained of in the early part of the morning. That is a rest pain or the morning stiffness. But if it is a constant pain, no relieving factor, it may be infective or neoplastic. So how do you know this? So now the question, now your job is very over. So over whole spine cases, you can just you sort it out whether it is a mechanical, inflammatory, and neoplastic. Now the infective one, now there will be local finding. Suppose I already told you, if it is a tubercular spondylitis, there will be tenderness, there will be deformity, and the pattern of movement. So as the brunt is coming from the front, so the motor will involve first, followed by the sensory and the bladder ball, which remains posterior part. Whereas if it is a neoplastic, which is most commonly it is a intramedullary. So it is a non-geographic pain, the diffuse pain or funicular pain. I already saw, and as it is coming from the back, because pedicle is mostly commonly involved. In the infective, the tubercular spondylitis, vertebral body is involved, which is anterior to the cord. Whereas in the neoplastic disease, the pedicle is involved, which is posterior to the cord. So that is why the early bladder balance is sensory, motor will be late, may be late. So this is the pattern you can easily diagnose. Now, the how to know the upper motor neuron? That means the myelopathy I will discuss later in the next slide. Lower motor, it may be radiculopathy, it may be brachial plexopathy, or it may be maybe neuropathy, that depending on the involvement of the spinal segment, nerve root, and the peripheral nerve. So this is the very another important slide. You can use see if there is a localized weakness, paralysis or paralysis of a limb, of any muscles of the limb. So we have to check it out whether the pain, paresthesia, paralysis or paralysis is a non-geographical pattern or it is a geographical pattern. If it is a non-geographical pain, non-geographical paresthesia, it may be myelopathy. How to diagnose? There will be diffuse pain, there is a sensory loss, dysreflexia. It may be areflexia or hyperreflexia, or if there's a flaccid or spastic, there is abnormal tone. Really, it may be rigidity, and there is a specific pattern of involvement. But if it is a plexopathy, it is a brachial plexopathy or the lumbosacral plexopathy. There's a pain, severe pain, excruciating pain of the wide area, and paresthesia and paralysis of the multiple nerve involvement. Whereas in the radiculopathy, it is a particularly radicular pain, as a claudicular pain, claudication pain I already discussed. There may be sensory loss, which is particular affecting the spinal segment. Whereas the neuropathy, pain, sensory loss, paralysis, everything will follow the specific nerve distribution. Radiculopathy, that will follow the spinal segment. Suppose it is the L5. Use L5 spinal segment. So in that case, there will be the extensor hallucis longus, that is the extension of the great toe will be paralyzed, as also the gluteus medius, this abduction also will be paralyzed. Whereas the neuropathy, if it is only the superficial peroneal nerve is paralyzed, there is only the extensor pollicis, extensor hallucis longus is paralyzed, not the gluteus medius. So in this way, we can differentiate whether it is radiculopathy or the neuropathy. So this is a very important slide. Now we'll discuss now the neurology. See, there are several scales. There's a modified Ashok scale. There are different type of scale we can use. This is a theoretical, but this is a very important slide. This spinal segment in your fingertips. Now, how to discuss? Now, see, if any student will practice in this manner. So adopt this position. That means the abduction of the shoulder. It is C5. Hold it in this position. Now it is look like 6. Now elbow flexion C5, C6, wrist dorsiflexor C6, and this C6 is this is it looks like this 6. That means the index and the thumb its sensation is contributed by the C6. Now this C7, it looks like a 7, isn't it? So now the middle finger, its sensation is contributed by the C7, whereas the fingers flexion, fingers that is metacarpophalangeal flexion, as a wrist palmar flexion, and the elbow extension, it is a C7. Whereas if you make it like this, if you like a C8, whereas you can open the fingers and there is abduction adduction, it is a 8-1. It's a T1. So this is C8 and T1. So this is it is very easy to remember. Now if you keep your position like this, that is hip flexion, knee extension, ankle dorsiflexion, and the great toe extension. Now we go by this L2 3 3 4. Now add 1 along with 1, L3 4. Now it is again the last one is L4. And now if it is L4 L5, then it is L5. Now, if you plantar flex the great toe, it will be just opposite. That is S1. If it is the L4, now it is the L5 S1. If it is the L3 4, next segment will be for the hamstring. That is the knee flexion is, if it is the extension is L3 L4, knee flexion should be the L5 S1. If the hip flexion is the L2 L3, now hip extension should be just this next segment, that is the L4 L5. So if it is in front of the hip, flexion is the L2 L3, hip extension is just opposite, the 4 5 maybe 1. Knee extension is L3 L4, knee flexion should be just for the next one, that is the 5 S1. Now if the ankle dorsiflexion, that is tibialis anterior, is the L4, now the gastrosoleus should be just the next one, that is the L5 S1. If the extensor hallucis longa is L5, flexor hallucis longa should be S1. So it's very easy to remember now. Now these are the jobs. Now I'm going to discuss the rhythm. So these are the 1 2 3 4 5 6 7 8. Just you can every student please follow by this rhythm. This is the rhythm which is taught for the toddlers, for the child. 1 2, buckle my shoe. Buckle my shoe means this ankle jab. 3 4, kick the door. If the kick the door means if you make a tap on the patellar tendon, there is a jerk. That is like a kick the door. Okay. 1 2, buckle my shoe. 3 4, kick the door. 5 6, it is a pick up the sticks. Pick up the sticks means some sticks are kept in your table. You are trying to pick up from the table to your body. So pick up the sticks, that means you require flexion of the elbow. So it is a biceps. Biceps jerk is the 5 6. Now 7 8, it is a lay them straight. 7 8, lay them straight. That means again with all the sticks, please keep it in your table straight. So again I am repeating: 1 2, buckle my shoe. 3 4, kick the door. 5 6, pick up the sticks. And 7 8, lay them straight. So you can easily understand, you can easily remember. This is a very important for your small spinal segment at a glance in your fingertips. Now for the spine, we have to, these are the components to be followed for the spine cases. So anatomical, we have to understand the vertebral level, that will be dictated by the tenderness and the deformity. Neurological level, it is depending on the motor and the sensory. Just I am discussed how low this ascertain the motor and the sensory. And for the sensory, you have to go from the below upwards and again from upward downwards to find out the sensory. Suppose at the level of the umbilicals, so it is, there is a hypo and a hyposthetic area. So it is in a D10 spinal segment. D10, that is the spinal cord is a D10 level, but then the vertebral level should be D7. That is because 7 plus 3 equal to 10. So they have all, I think all of you know, in cervical region, add 1. That is a dorsal. That is up to D6. It is add 2. 7, 8, 9, add 3. Like this. So you can easily, it is like a mathematics. Spine is a very usual. Now, some students, it is thought very crucial one. It is a it's a like a mathematics. So anatomical level, you have to understand the vertebral and the neurological level. Pathological, you have to understand whether it is extradural or the intradural compression. If it is extradural, that means the brunt is coming from the outside. That means if it is just time we discussed, if it is a carry spine, as it's a vertebral body is the common involved. So there the motor involved first, followed by the sensory, and the bladder valve is the last. If it is the intradural compression, like any neoplastic condition which is commonly intradural, so it is coming from the posterior aspect of the bladder valve involvement first, followed by the sensory and the motor. Now the etiology, it is simply mechanical, infective. It is very easy. I already told several hints how you can know whether it is a mechanical or neoplastic, like that. Now the duration and the progression, whether it is deteriorating or improving, there is a disease of progression, I already told, and the complications like the bladder valve involvement. So these are the points to be involved. Suppose I am telling, it is an example. It is a case of tubercular spondylitis affecting the D12L1 vertebra. The spinal cord level, it is maybe L1 L2. This is a pathological, it is a extradural compression. Etiology, it is a chronic infective lesion. Most commonly, it is a tuberculosis of 3 years duration or 3 months duration, which is gradually progressive in nature, of being untreated and with or without bladder bile involvement. So in this way, you have to complete your diagnosis of the spine. Now, I'm giving some example of these common diseases. Like suppose it is a case, all of you know, it is a cubitus veras of 2 years duration on the right dominant side, as you can see here, following the malunited supracornular fracture without elbow stiffness, neurovascular deficit, with or without limb length discrepancy in a 6 years old boy. So this is the technique. Now, what is the diagnosis in this case? Suppose in this one, left one, is a bilateral congenital idiopathic, untreated, resistant type of CTV of 3 months baby. So everybody, now the next question will be, what are the points in favor of your diagnosis? Now you start telling why it is congenital, why it is idiopathic, why it is untreated. Don't utter it is a neglected. Now it is previously it is called neglected. Now they should not utter the term neglected. Now what are the possibility? Every possibility should be kept in your differential diagnosis. Now see, this one is a droptosine. It is a neurogenic clubfoot. You can see here, and so whereas this is the small the dorsiflex clubfoot, it is a atypical resistant type of clubfoot. This is the skew foot. You can see here, this is the jet-shaped foot or skew foot. So everything we have to keep it in our mind. Now for the radiograph, we have to find it out the baby CD. The A for the age. Age is adequacy. Adequacy means any long bone should have the joint proximal and the joint distal. Now, so B for the bones. Which bone is involved? C for C actually basically the cortical outline. When the cortical outline is broken, suppose it is here with the articular involvement, and D for the displacement. Now the question is, how to know this angulation and the tilt? The angulation is basically, you can see here the angulation as a for the diaphyseal region, the angulatory deformity, you can tell it's angulation, whereas the angulatory same angulatory deformity for the juxta-articular lesion, you can tell in the form of the tilt. So tilt is basically, it is a right angle. It is basically it is tilt is basically the direction of the articular surface of the distal fragment. So this is the tilt. Now there are different lines and angles. I'm not going into detail. So if you are very much confident about the basic, then you will be asked what are the different lines, the Bowman's line that. Now the spot diagnosis. Now rickets. Just I have kept it. The AS is capital. It's a bold. Why? There's most of the students it write or tell it is a ricket. No, it is actual term is rickets, because there are several bones are involved. So that is why it is called rickets. So see this, there is a cupping, fraying, splaying, increase. What is the most important radiological finding? There is increased fascial space. This is the most important. Now this is the trident hand, and this which type of
Yes, sir.
just a minute.
Okay, sir.
So now the operation. Will you stop it, or just one or two, three slide we can discuss? To this slide, just what is asked in the operation, the preoperative checkup, anesthetic fitness. You have to prepare for this, everything. So incision, how to give the incision, muscle interval, like this. Now I'm just going into a very short time. So suppose there are three approaches of the hip. So you can write it down. For the first layer anatomy is the gluteus maximus, fascia lata in the lateral side. In front there is a TFL and sartorius. And second layer is the rotators, gluteus medius, and the anterior approach is in between this. Lateral approach is through the fascia lata, gluteus medius minimus. And then posterior is through this gluteus maximus, followed by the splitting of the gluteus maximus, followed by the lateral rotators. So this is a usual way you can do that. Now instruments, you have to find it out the name, parts, use, modification, and the limitation. So these are the things is asked in the implants. So again, if this then some recent advances you can be asked. Now for the orthotics prosthetics, we have to tell the nomenclature, parts with the function, how to wear, there is donning and doffing, indication, contraindication, limitation, complications, guidelines. Now, for prosthesis, you have to tell the nomenclature, parts with the function, indication, contraindication, complications, guidelines, and advice for use. Now, I'm just going into very, very small tips. Like for the classification, don't be a very big classification. So the joints encompassed by the orthosis, that indicates its classification. Like the foot, that is foot orthosis, ankle foot orthosis, knee ankle foot orthosis, like this. Upper limb is a finger orthosis, hand orthosis, like this is very easy. Now, indication is a wild. W for the is universal indication. So if you remember this, you can tell anything like W for the weakness, that is the UMN element, that is insensible foot. L for the loss of structural integrity, like this, and D for the deformity. So wild, if you remember wild, it's now easy to. Now I'm not going to detail. Now specimen, for the specimen you have to find it out. We have to identify the parent bone. We have to identify the lesion, whether it is a nature, it is a malignant lesion or anything, any type of infected lesion. Location, it may be located in the epiphysis, metaphysis, and the diaphysis. Type, so suppose it is a type. So the cecostem is a type of the cecostem cause fate, like this. In the spine, you have to identify the cervical, dorsal, lumbar, location of the disease. There is infection, neoplastic, like this. So suppose this example it is given here. Now, for the research, it is a table 4 in Viva. They can be asked what are the types of research that most of the cases that are related with your thesis topic. Now, just I'm just keeping all the OSCE because there are several. Just I'm finishing my talk on this. So this is the last minute talk. That is a solve 10 years question paper. Practice to write the answers. Practice to write the long case finding. Practice to present the long and short cases to peers, juniors, seniors, and faculty. Even to the even you can practice in front of a mirror. Practice to make a plan of the management, check it for its correctiveness, and discuss. Yeah, this catharsis is a very, very important. And day of examination, you have to have absolute sleep, hydration, and the light food. Keep the exam kit bag. I'm just going to discuss what should be in your kit bag. So this is the most important. So these are the absolutely necessary in your kit bag. And then this is asked how to use. Suppose it is a tuning fork. So tuning fork should be of 128 hertz, and most important is the time vibration. Now for this one, which why there is striking surface, two striking surfaces for specific for identifying this specific jerk. So if the tendon is very small, so you have to use this. Suppose it is ankle jack, we have to use the large broad one. If it is a biceps jack, we have to use the small one. So this is the utility of two striking surface. Now it's better to have this. So we have to gain the confidence of the pediatric age group to have the biscuits, and this is this one. And for the hip disease, if you bestow this sort of affection to the patient is a very will very happy and will be coordinated. Now this is a very, very important for the 2 point discrimination, which I have learned it. So it is basically it is a simple gems clip. So you can use this for the cortical cortical sense, as also during the recovery of the nerve. This is, you can see, you can measure it, how much the distance you can differentiate in your hand, in your palm, in your back, like this. And this is the goniometer. So I think take home message, you have to know yourself, you have to plan, personalize, implement your plan in due course of time. And most of the cases you have to understand you have to the exactly become the master if you practice it. Thank you.
Thank you very much, Dr. Pal. As usual, excellent talk and a lot of useful tips there. And I'm sure there'll be some questions, so let's take over the questions.
So while we are waiting for the question, just one or two points like how much to expose in lower limb case or hip and
Yes.
in upper limb case.
Exposure is very, very important for the female. Before exposure, always call for the female attendant. That is very, very important. And also the screen. So always there's some exam moderator. So you have to call for the moderator first. So I want some screen, and also for the female, I have a female attendant. This is one. For the female, I should not expose, that depend on your patients. And most of the cases, the hip cases are not given for the female. So it is now is easy. And for the male, for you have to use. I have already shown if you give a if you Frenchy like that, it is very easy. That means your bony points, that is anterosophiliac spine, should be exposed, but your genitalia, basically your genitalia will be covered. Your natal cleft will be covered if you examine from the back. So your Frenchy will be very much sufficient enough with a screen. Screen is extremely screen, and for the female attendant. So to be for the male patients, the upper body you can completely remove it, remove all the clothes. And for the lower, only you have to cover the genitalia and the natal cleft, like the Frenchy, like this.
And so, like in a spine and hip examination, we say that it is not complete without doing PR. So
Absolutely,
for
absolutely.
rectal examination,
Absolutely. So this is a very, very important question you have asked. So in most of the cases, if there is some carry spine, so carry spine, suppose it is in the lower dorsal spine or the dorsolumbar region. So it is mandatory to examine the rectal. So in that case, we have to ask your moderator to provide some gloves, and also the local anesthetic like the Gylocan jelly. And we have to make the patient completely understand. We have to take that I am going to examine you, and please be cooperate with me, and what is going on. We have to completely explain to him. Now we have to do this. Okay, that is anal reflex, bulbocavernosus reflex, as also the parectal examination. These three are very, very important for spine.
so it is like in last exam, few of the DNVs was telling it was 10 minutes for one case. There was two cases and 10 minutes for each case. So how to examine a hip case or any other case in 10 minutes, sir?
Yes, now the trend is going on. Every cases should be the same category. There will be no sort of long case or short case. So the examiners are also select those sort of cases where the findings are very easily picked up. I'm giving the example. Suppose there is a avascular necrosis of the femoral head with some secondary degenerative arthritis. So in that case, we have to give very small, very little amount, only 5 minutes. You can take for the history. That is what is going on. That you have to for broad category. There should you have to exclude the significant trauma. So there is if there's some history of some taking medicines like steroid medicine, even a single steroid dose, even in post-COVID era, that can lead to avascular necrosis. So we have to find it out. So in favor of a diet, that means single dose of steroid, or there are some other drugs which can produce some or alcohol like this. So we have to take from the history. Now, from the examination, if it is a only there is a avascular necrosis with early osteoarthrosis, that means at the anterior hip point, we have to make systematic examination. From standing, we have to check from front, side, back. So in avascular necrosis, if there is only is very significant, if it is early one, very little amount of inspectory finding, we will not get any much. So so don't concentrate much on. So if you come with the palpation, there is anterior hip point, may be tender with or without tenderness. But the most important, it's the movements. I've shown it. The movement is very, very important. So if it is all movements are affected and the terminally affected, that means it is a arthritis, and pain is from that is synovitis or arthritis on the background of taking medicine. So it is most of the cases it is a secondary degenerative arthritis following avascular necrosis. And another important investigation you have to finding you have to find it out. There is rest pain. If it is a avascular necrosis, there will be most commonly there is a rest pain. Rest pain, or there is a, when the patient lies down in the night, patient is complaining of rest pain, not the night cry. So that is most important. So and all other features will become absolutely negative. That means the telescopic will be absolutely negative. Trendelenburg, yes, may or may not be positive, but so in that case, you can within 10 minutes we can finish it out. So in this way, we can, so on inspection, you enumerate all the findings, all the examination from standing, sitting, From standing, complete all the examination. From supine, complete all the examination. From prone, you have complete all the examination like this.
And so no need to write anything.
No, no, no need to write. No need to write.
Yeah, but you need to clearly document your findings, and then whether you write it or not, you need to be clear about what your findings are. So it's something that you have to develop with practice. That's basically the only answer.
Absolutely, absolutely right. You are. That is, I have shown that there is one notebook. So notebook is very, very important. Once we have find it out, we just make it out. That is a entry point. It is a very important if it is negative or not. Like this true shortening present or not. Like this, just salient points.
Exactly.
So if something to be prepared before going to exam, like on a plain paper, so that when you're examining, you can write it down to save times, right?
Yes, yes.
Okay, sir. And so, because how much of that grammatical error while uh, presenting a case is allowed?
No problem at all. So I found several students, there are some grammatical problem, English problem, English speaking problem. Some are very, their बोलने से तेरा problem हो रहा है तेरा their that they then cannot express, but don't problem at all. We have to make it your cool. And I think my suggestion is every student should try to write it down, just John sir just mentioned. Write it down your findings before exam, during your practice session. Write it down and make a summary writing. If you write a summary writing, summary of the history, summary of the inspection, summary of the palpation like this, now it is very easy to prepare, express it. It is very, very good, useful.
I think the problem is uh, your language kind of slightly depends on the examiner. I mean, there's most people are now sensible and they will not penalize you for bad language. But every now and then you'll have someone who will insist on little things that make a difference. And so you have to be prepared. You need to keep, that's what I'm saying, you have to keep practicing to present the case. And once you do that, then how, however bad your language is, you should be able to get the key points out.
Absolutely. Absolutely.
Yes. So I think there is not much questions in the chat box. So I think we can.
Thank you very much, Dr. Pal. And I think
Yes,
the presentation was so clear that most of the students don't think that they need to ask questions. But I think they should realize that this is the time they should be asking questions because that's the best way to clear their doubts. So anyway, I think till next time, thank you very much, and we'll hope to see you
yes.
again next week. Okay, bye.
Thank you very much, sir.
Thank you. Thank you.
Bye.
Thank you.